Every 2 minutes, cervical cancer claims a woman's life. That adds up to over 340,000 deaths every single year. Biologically, this disease begins with the uncontrollable malignant growth of cells in the lining of the cervix. But unlike most forms of cancer, the biological path to cervical cancer is well understood, and the means to block it already exist in clinical practice. The mortality rate persists despite the fact that the international health community has reached a consensus on the specific methods required to prevent nearly every case. The burden of this disease is heavily skewed by geography and access to healthcare. This map shows the global distribution of cervical cancer. 88% of all cases occur in low and middle-income countries, where healthcare infrastructure struggles to provide routine screening and prevention. Biological risk factors compound these geographic disparities. For women living with HIV, compromised immune systems make the risk of developing cervical cancer 6 times higher. Cervical cancer targets inequity, exploiting existing gaps in global health resources and vulnerable immune systems. Over 90% of cervical cancers are caused by a single pathogen, the Human Papillomavirus, or HPV. It is the most common viral infection of the reproductive tract. Almost all sexually active individuals will contract it at some point, though the vast majority of immune systems clear the virus naturally. Out of dozens of strains, a specific group is categorized as high risk or oncogenic. Types 16 and 18 alone are responsible for 71% of all cervical cancer cases globally. The danger arises when an infection by these high-risk strains becomes persistent. Over time, the lingering virus slowly alters the epithelial cells lining the cervix. A common temporary infection transforms into a permanent cellular mutation, simply through silent persistence. This timeline illustrates the progression from initial HPV infection to invasive carcinoma. The entire process typically takes 15 to 20 years. During the first decade or more, as precancerous lesions form, the virus acts as a silent invader. There are absolutely no warning signs or symptoms. Symptoms like abnormal bleeding and pelvic pain only manifest at the extreme end of the timeline, once the disease has progressed to advanced invasive cancer. That 2-decade delay provides an intervention window. Routine screening through pap smears and HPV DNA testing allows clinicians to find abnormal cells under a microscope long before they turn malignant. Once detected, these precancerous lesions can be destroyed using simple ablative methods, such as cryotherapy. Screening effectively intercepts the disease mid-process, but the ultimate goal is to stop the virus from infecting those cells in the first place. The foundational pillar of the global elimination strategy is the prophylactic HPV vaccine, licensed in 2006. This diagram compares a real virus with the vaccine's active component. The vaccine uses virus-like particles, empty protein shells that mimic the shape of HPV, but contain no infectious viral DNA. Looking identical to the virus, these empty shells safely trick the body into mounting a robust immune response, generating a long-lasting supply of antibodies. Current vaccines target the deadliest strains, including 16 and 18. In individuals with no prior exposure, they provide near 100% protection against the precancerous lesions those specific strains cause. This shifts the medical approach. Rather than fighting a defensive war against cancer cells, the body proactively neutralizes the virus that spawns them. To guarantee this protection, the optimal delivery window is between the ages of 9 and 14, ensuring immunity is built before any potential exposure to the virus. Originally, guidelines required a multi-dose schedule. Returning from multiple shots presented severe logistical challenges, especially in the lower-income nations where the disease is most prevalent. Recent clinical data prompted a major policy update from the World Health Organization. A single dose of the HPV vaccine is sufficient to elicit a highly protective immune response. This chart compares protection levels across dosages. Clinical evidence shows that a single dose provides over 97% efficacy against persistent, high-risk infections 18 months after vaccination, achieving parity with the multi-dose regimens. Reducing the requirement to a single injection removes the primary logistical barrier for health systems in remote or under-resourced regions, bringing global elimination within reach. Through the combined application of routine screening and universal childhood vaccination, it is now possible to remove cervical cancer from the human experience.